Welcome to our fourth International GP Recruitment broadcast. This broadcast is titled The GP Looking After the Whole Person, and we're really looking forward to chatting to you about how the GP doesn't just look after one person, the patient, but actually thinks about the whole person and how they fit into the patient's family, the person's family. So really looking forward to chatting to you about that today. You will remember me from before. I'm Kim Tolley. I work for the General Medical Council and also the International GP Recruitment Programme. And Maureen.
Yeah, so I'm Dr. Maureen Tahir. I'm a GP in South London, but I'm also one of the clinical leads for the International GP Recruitment Programme for NHS England.
So we thought it would be really nice to just remind everybody what we looked at in the last broadcast. I don't know about you, but it was quite a while ago. So we looked at GP premises and what's important, and we had a look around Maureen's GP practice, which was quite exciting. We looked at the patient survey and the information it actually gives you, and I think it's important when you start in a GP practice to have a look at things and look at what the patients actually say about your surgery. It gives you a real insight into patient experience. We looked at the consultation, and we also looked at Mrs. Thomas coming into the consultation. We looked at consultation models, which I have to be pretty naive. I didn't even know there were such things, Maureen, but obviously that you use those to structure your consultation every day.
We do, and since my last broadcast, I've been thinking a little bit about the patients that I'm seeing and recognise actually I've picked up bits that I like of each model, and I do use them every day. So if you missed that, go back and have a look at that broadcast again, and also look up consultation models. There's a few that I named in the last broadcast, but there's so many and lots of books written about it. So I find that really interesting and something I suggest that you have a look at when you've got a bit of time.
And we looked at fit notes, what I, in years gone by, would have known as a sick note.
Yeah.
It's fascinating to think that we've changed from the terminology, makes it sound much more positive, like I'm looking forward to getting back to work. Work plays an important part in your life, doesn't it?
Absolutely. And I think as the NHS, we're celebrating the well patient rather than the unwell patient. So, telling people that they are fit to go to work rather than putting a negative spin on it, it's actually been really helpful.
Yeah.
Lots of programmes have been born around that, recognising the importance of work and how you can get people back to work, because we know that it's a really important health indicator.
And I remember years ago I learnt a lot about the sick role, and patients, when they become sick, one of the things they do is they don't work, but also they take on this role of being sick. And so it's worth looking at the sick role, actually. It's quite interesting. So in this broadcast, we're going to look a lot more about the role of the family, and we're going to meet Mrs. Thomas's son, Jack. We're going to look at how that links with confidentiality and how complicated that is. And I know Maureen and I have had lots of conversations about confidentiality in GP practice. We'll remind a little bit more about the referral process and really the other members of the multidisciplinary team. We're going to look particularly at the pharmacist, Solomon, your pharmacist, and find out what he does in the GP practice. So that's the sort of structure of today. Remembering that it's an hour long, we finish at 1 o'clock. It will be recorded and uploaded onto the 14 Fish website, and it is also just about to be put onto the NHS England website. It will remain on that website for 6 months, so you do need to be aware of that when you type in questions into the side part of your screen, the left-hand side of your screen. Just need to be remembered that it will stay up there. So data protection, is really important in these situations, and you do need to remember that. But there will be a discussion board on the side, so please, Nick, our trusted colleague, is going to read out some of your questions as we go along, and they will remain up there, and we'll hopefully answer those as we go along. If you don't get round to your question or we don't get round to it, please email Maureen and I. I've had quite a few emails since the broadcasts, people sending emails in, and I really love answering questions. So I think that's really, really, really good. So there will be opportunities. So as usual, a bit of a plea, really. We'd love to hear where you come from. It's just really helpful. Maureen has spent the last week at a conference in
Europe. Yeah, so I went to Slovakia, went to the Wonka conference. Some of you may have met me there. So thank you for joining us. Really interesting experience. Met lots of GPs from around Europe and outside of Europe. And it was just fantastic hearing about your journeys. As I keep going on, I'm really fascinated by all the skills and the backgrounds that you all have. And I think we're really lucky to be able to have this programme in NHS England, where we can support your transition from your country and your healthcare system to England and our great NHS.
And make it a supportive journey rather than a scary journey, really. It's really important. So yes, we'd love to hear from you. That would be really, really nice. So we're going to start with our usual top 2 poll questions. Sorry about these again, but they're really useful information for us. So the first one is very much about where you are at the moment. Do you live in the EEA? Are you working? Do you not live in the area? Are you from a recruitment agency? It's just really helpful to know that. So if you could possibly just complete that for us, it'd be really helpful. It's just a really good feel for who's in the audience and how that actually works. So the poll is up now. So just pop your answers into the poll. That would be really, really useful. Oh, okay. So we'll move to the next poll. And the next poll is where you are on your GP journey. And that's the other really important thing we'd like to know. You know, have you started the International GP Recruitment Programme? Have you not started it? So that's really helpful to us as well. And again, it gives us a real feel, doesn't it, for what's going on. Okay. Okay, so we'll move on to the next slide now. Thanks. Lila, our lovely lady, is helping us with the slides today, so that's really, really helpful. So we met Mrs. Thomas, didn't we? She's been sort of weaving in and out of all our broadcasts, and she's 58, just a reminder. She lives with her son in a semi-detached house on the outskirts of town. She's found a breast lump and she wants to make an appointment with her GP. And we've seen her booking that appointment, we've seen her coming to see the GP, and we just wanted to start this presentation, you know, a little bit more about what actually happens in the referral and what the referral process is about for her. So in a minute, we're going to actually show you a video of Mrs. Thomas and how she gets on when she meets Dr. Kowalski. So a little bit more about her, because it is quite important that we remind you, because as I said, later on, Jack's going to come into the scenario, and we're going to see what happens to Jack. So we'll just move on to the next slide, which is all about the referral process, and see what actually happens. So the next slide is Dr. Kowalski and Mrs. Thomas actually chatting after the consultation. So let's see what happens next.
So I think this is really interesting, Kim. Going back to some of the things that we spoke about in our previous broadcast, the way the doctor conducted the consultation was actually really impressive, really. She's safety netted, so she said, you know, if you don't receive anything in the next 2 weeks, then please come back. She's also checked contact details, which are really important, and checked that the patient's actually around for the appointment. And something really important is that she shared that decision-making process. And that's something that we're really keen on as GPs in England. We want our patients to be involved in decisions about their care, and we want to ensure they have the autonomy, but also make sure they make an informed decision. So giving them all the information, all the risks and benefits of some, you know, any intervention or referral even that you might be suggesting.
Because I know that, I mean, Dr. Kowalski was going to send her a letter, but I know in some surgeries, and you were certainly telling me in your surgery, you actually book the appointment with the patient in the room with you.
We do. So that's something I referred to very briefly earlier, which was the e-referral system. So if you remember, it's a service which is available in most GP practices where patients can, well, you as a doctor or a member of your administration staff can actually access waiting books, so appointment books for different hospitals. So for example, if you know that a patient wants to go to a certain hospital, they might say, actually, I know that one's a bit further away, but I can get a bus there, so it's much easier for me. You can actually look up appointments and actually book them appointment there and then, and hand them the letter that they would have received in the post. So that's really useful. I found it's really helped me as a GP. There were sometimes patients that I was worried about. I thought, I've made the referral, I don't know how long they're going to have to wait. Actually, their problem is not that urgent, but I wouldn't want them to wait months and months. And I never really knew, without making a lot of phone calls and emails, when their appointment would be. Now it's very simple. I'm booking it, and we book it at a convenient time for the patient, so we know that there's more likelihood of them attending.
And I was at a conference last week with the Parliamentary and Health Service Ombudsman, who was telling me that they get a lot of complaints from patients for having to travel so far. So, for example, if you live in an area and then your local hospital doesn't do that speciality appointment, you have to go much further. And if you could have that conversation with the patient in the room about how you were going to get there, is it feasible for you to get there, then it's much more informed, isn't it?
Absolutely. And sometimes there are what we call tertiary hospitals. And again, I'm talking about something we talked about in broadcast 1, which was the structure of the NHS. So acute trusts, so that's usually hospitals. They sometimes have super specialised hospitals, if you like, what we call tertiary centres, where it's actually beneficial for the patient to be seen by someone who specialises in a speciality in that hospital. And it can be difficult for a patient to understand that when they get a letter through their door and don't have that information. So the benefit of this system is actually you can tell them, actually, that's a really useful place for you to go to, because actually there's someone that's a real expert in that field for your particular problem, and patients usually appreciate that.
And I think the complaint, they had a lovely case study in their annual report, and that complaint was actually from a patient who that actually happened to. And if that patient, you'd had that joint decision making, that shared decision making, and the patient had understood why they'd been sent so far away, it would have been completely different, I think.
Absolutely. So go and look up what system you use in your practice. Like I said, most practices are using the e-referral system. The thing that does vary amongst practice to practice is who books the appointment. So in my practice, we do it during the consultation, and it's relatively quick. Now I've sort of worked my way around the system. In other practices, it might be an administrative member of the team. So it may be a secretary who books the appointments and then contacts the patients. But find out what's happening in your practice, speak to your supervisor, get have a play around with the e-referral system. Something else I found really interesting about the system was that actually I learned about a lot of clinics I didn't even know existed. So actually you can list out in every you see a list of all the different clinics in that speciality. So there are some ones that I really didn't know about. So have a play around and see what you find.
And how reassuring for Mrs. Thomas to actually leave the consultation with the next step.
Absolutely.
Instead of sitting at home waiting and worrying.
It was a really positive step for general practice to be able to access, appointment books of our colleagues. It's really changed things for my practice, I'm sure.
But I know that you mentioned in the next slide is how there are lots of other specialties that you can link up with. So, for example, transient ischemic attack, you can actually directly refer to a clinic, can't you?
You can. So in this slide, it looks quite complicated, but it's just a few of the services which are slightly different to the normal clinic that you might refer to if you want a patient to be seen by a specialist. So these are sort of clinics which are set up for problems which are not requiring A&E, but require urgent help. So, for example, we have a first fit clinic. So, obviously, someone's had a first seizure, they're going to be worried, you're going to be worried. It's very difficult to work out exactly what might be causing that seizure in your 10-minute appointment, and they probably need a few more investigations, but quite quickly. So, actually, you can refer them to a first fit clinic. There's a time period in which they're guaranteed an appointment in our areas within a week, and at that appointment actually they're getting access to all the blood tests or imaging, and perhaps seeing a specialist or a specialist nurse, so that that they've got a good management plan.
And I think it sounds to me sometimes like that your GP is quite a lonely job. You're in the room on your own with the patient, aren't you?
Absolutely.
But actually there's this wraparound service. There are other people out there who you can phone up and ask for help.
Absolutely, and that's what I really like about these services. I mean, another one which I use a lot is the paediatrician on call. So actually we have a mobile number for the consultant who is on call for that day, and they're really happy for you to phone them and say, look, I've got this little child, they seem a bit off, they've got a bit of a temperature, but actually they've come up with this rash. It's non-blanching, but it doesn't quite look like a virus. I'm a bit concerned. And most often than not, either you'll get really good advice and a plan with a follow-up plan, you learn things
Yes.
as well. So that's a really useful tool because of this communication you're having with your secondary care colleagues. But you also get the best patient care, really. So that patient might be seen that day by the paediatrician on call, rather than having to put them in for an appointment, by which point either something more serious has happened or the rash has disappeared. So services like that, and these do vary again from area to area. So you might have access, you might not have a paediatrician on call, but you might have something else. Like they're often known as hot clinics. So you might have in our area, the rapid access neurology clinic is called a hot clinic. So find out what your area has access to, and find out what those services are, because it's really useful. It's a reassurance for us. And the other place I would suggest having a look is in your IT system. So there's lots of pro formas usually for these clinics, because often there's certain things that the clinic wants to know, because they're only seeing one sort of type of problem, if you like. Performers, I actually learned quite a lot. For example, the TIA clinic, which says, have you the blood pressure? Is it below this? Is it below this? And it's got a bit of an algorithm. So actually, it might be that you thought someone might need to go to the TIA clinic, but actually they need to go to them. And it's difficult to make that call sometimes. You might have had symptoms 7 or 8 hours ago. There might be something in their history which actually a specialist would say, no, still go to A&E rather than come to our clinic, and vice versa.
And there are lots of other referral routes which Lila's kindly put on our screen there. You can refer them to phlebotomy, obviously, in 24 hours. Recording, blood pressure. It's actually really lots of
it is. And I mean, these services are available in your practice. Some of them might be available at a local practice. Some of them you might not have access to. So you might have to send everyone needs, for the blood taking, to sit in a walk-in clinic. But that again varies from area to area. And so I would say though is actually the London is a really useful tool. So, do there actually doctors that work for the London Ambulance?
Who can give you clinical advice then? Or?
They can. So, somebody they need to go in as what we call a blue light, which is in the London Ambulance or whatever ambulance services relevant to your area. And there's usually a board of clinicians you can have a chat with, and they might redirect you to another service that they know about, which is more appropriate for that patient.
I love the idea that GP practice, if you're brave enough and sensible enough, you'll definitely ask other people for help, really.
Yeah, and that's really important. I know a lot of people that I've met from Europe have an A&E, an accident emergency background. So actually you might be really confident managing someone who's, desaturating, or a child having a really bad asthma attack, because actually we do have some emergency kit. But actually it's not about you, it's about, making sure that that patient is supported in the right environment. It's really important. And sometimes the GP practice is not the right environment. You can't admit them, you can't observe them. If something were to happen, you don't have all the drugs available. So although you will be competent in managing some emergencies, don't be worried or feel bad. In fact, you should call 999 or the ambulance to get the patient the best care that they can have in the right place.
So that's just another slide we put up last time as a reminder, isn't it? And I think for me the really big thing was that red box, really. That's the important bit, isn't it?
Yeah, so I thought we'd just have a quick recap of some of the things. I mean, it should be in your referral letter, and you can see there's obvious things like making sure it's the right patient details and past medical history, whatnot. But the red box is the question for the specialist. And I sort of learned this the hard way. So I once had a patient who had a really persistent rash on their chest, just was not getting better. We tried steroids, we tried lots of different emollients. I sent off scrapings to see if it's a fungal rash, and nothing came back and didn't look like a fungal rash. So actually I thought, no, now we've tried a lot of things, it's getting worse, let's send you to the specialist. So this was before the time of ERS, so the electronic referral system. So I sent off this letter for a referral to get the patient appointment. The patient got a letter in the post, they went to their appointment, but I wasn't quite clear on the referral which rash it was that I was referring to. And actually the patient attended the appointment, came back to see me and said, the dermatologist was great, they've sorted me out. I said, what do they give you? And he said, look, the rash on my ankle has disappeared.
The other rash.
The other rash. So actually, maybe it was a good thing. The patient's concerns obviously are very important, and that was obviously more important to him than this rash on the chest that I was worried about. But if I'd been clearer, perhaps the dermatologist would have looked at both rashes and provided an answer, because we still persisted with the rash on the chest.
Yes, there you go. So a good good vision, really. So we're going to go to a next slide, which is actually questions, Nick. And do we have any questions at all that we need to answer on the discussion board?
Yeah, there's no questions at the moment, but we've got Adams is joining us from Nigeria.
Oh, fabulous.
Hi,
Brilliant.
welcome.
Thank you very much. Okay, so let's look at the next slide. Really, we want to move this whole Mrs. Thomas scenario on to look at her son, really. Her son's Jack. We've not met him before, and we're going to meet Jack in the next part of the video. Jack comes along with a completely different situation, really, and a completely different medical problem. And this often happens because you as a GP would see the whole family sometimes, wouldn't you?
That's often
different
the
generations.
Case. Often the case, and you'll see them having grown up. You will have seen them coming in with their mum, and then the mum become a grandma, and so you live the patient's family with them. So you might already know Jack, and he knows that his mum probably comes to see you because you're their family doctor.
Yeah. So let's see the next video, which is Jack coming in to see Dr. Kowalski, if that's okay. Right, that's a difficult one, isn't it, Maureen? I'm sure the situation you've been in many times. So let's have a think about what you think Dr. Kowalski might say before we actually look at the answer. So we're going to go to a quick poll. What do you think? Jack says, that's what he says, I know my mum's been to see you. I'm worried about what's happening. Do you think she'll be all right? Because, he's had a conversation with his mum. I popped up to the doctors. What should Dr. Kowalski do? What should he do? What should Dr. Kowalski do? What should she say to Jack? So let's have a see what you think about those situations. It's all related to confidentiality. So somebody said that you should listen to his concerns and explain about confidentiality. So probably the right answer.
That is well done.
So well done.
The person that's brave enough to answer the poll.
Which is always a bit scary. So let's move to the next slide. So this is really related to the GMC Confidentiality Guidance. I've got my guidance here. This is some really good guidance to read, and it's one of our core bits of guidance. Now, if you haven't got the guidance, we've said this before, you can order hard copies. If you literally go on our website and type in publications, we will send you free of charge our guidance. So have a look at our guidance and have a see what you think. So our confidentiality guidance is really clear in this situation, and it divides it into three parts really. Establishing what the patient wants, abiding by their wishes, if depending on capacity, and we'll talk about that in a minute, but listening to those close to the patient. I think that's one of the most important things. It's actually listening to Jack and seeing what he says really, and actually making that really clear. And is this a situation you find yourself in?
It's very common. So it might be something, where actually there wasn't a problem, where there was no issue about, possible breast cancer. It might be something very subtle, but it's very easy to reassure the patient and say, oh yeah, he was fine, she was fine, your wife is fine. But actually that's the wrong thing to do. Unless the patient has expressed a wish that their medical history should be shared with a particular member of their family.
They can actually do that, can't they? They can write a letter in, or you can document it if they say it.
Yeah, so we do have that for a lot of our patients. So, a husband will pick up blood tests for a patient, and that's documented clearly on one of the alerts. So if that's the case, that's different. But we don't know what Mrs. Thomas wants, and we don't know whether she's even told her son about what's going on, or whether there's a risk, that she might have breast cancer, or even that she's been to the doctor. He might have just seen it on the calendar and just wants to find out more. So it's really important to be careful to respect your patient's confidentiality, because that's paramount.
Yeah, and what in that situation, it's also that you might have to, if you listen to Jack and listen to his concerns, you need to also explain to him that if he shares stuff with you, you might actually have to tell his mum. There are situations where you might have to tell them. And I know that particularly with patients, maybe you come in, I don't know, if you're worried about your relative and you're really worried about your father who's getting a bit muddled, and you're worried about their mental health or anything like that.
So it is important to remember that actually it's not the patient's relative calling you up or asking you is because they're worried. And actually they can be a wealth of information. So, we've had cases, quite a few cases actually, where a relative has called up about a family member, like you suggested, who's becoming quite forgetful, and they're worried about their, whether they might have dementia. They're too worried or too anxious about speaking about the possibility of this to their relative, but they want to just let you know what's going on. And actually there's been cases where, the relative might say, you might decide actually the best thing to do is to speak to the patient, but the relative might say, don't tell my uncle that I phoned up, because he'll be really angry.
And what do you do in that situation?
Well, it is a tough situation because, you have to be honest with the patient. You can't lie. If you're going to take it further, the patient will wonder where you got this information from. So I usually explain to the relative that actually it shows that you're concerned. We know that you're far away, and your uncle knows that you don't see him as often, but he'll actually probably be quite pleased that you've taken the time.
You're bothered.
Absolutely, and usually that works. I've not really had a problem where a patient's been adamant or a relative has been, hasn't got over the fact that their relative has called up, because it's usually, a sort of conversation starter. So it allows us to have that conversation about whether there is actually something going on which you might need more support with.
And of course it influences how you treat the patient, how you assess them, doesn't it really? That information can be really like gold dust, really.
Absolutely, it's really important. So we involve families in lots of different sort of medical conditions, but you must have the patient's permission. That's really important.
So have a look at our guidance, as I said, plugging it again, but it says here that you might need to tell the patient about the information you've received from others. You must listen to what they say, really, and don't just say, I can't speak about this, this is not you, you're not my patient, I definitely can't speak to you, because that's actually
that's really important actually, because there might be a patient safety issue that you're going to miss by doing that. And like we said earlier, that relative might see the patient or speak to the patient much more than you do. In fact, they will. So their information is really important for it might be to make a diagnosis for you.
And we're all relatives as well. We totally understand that, don't we? We all care
Absolutely.
about our families and want to be part of information as well. So that's lovely. So let's move on to the next slide. We're actually going to read out what Dr. Kowalski actually says. So would you mind being Dr. Kowalski?
I'll be Dr. Kowalski. So, Jack, as a doctor, I cannot discuss whether a patient has come to see me or what they've seen me about without their permission. In the same way, I wouldn't disclose that you have come to see me about your ear today. I have to be careful to maintain patient confidentiality. And it can be difficult when we're worried about a close family member, such as your mum. What are you specifically worried about? And then Jack goes on to tell Dr. Kowalski that actually he's really worried because he knows that his mum's come to see her about a breast lump, and he just wants to know more. And Dr. Kowalski does offer some solutions, which you'll hear Jack talk about in the next video.
So before we go to the next video, we'll have a quick poll about if you had actually said that to Jack, how do you think he would have felt? Because actually, he might not be too happy about that sort of information, really. So we're going to ask you to think about how Jack feels. Was he annoyed? Was he cross? Was he actually less worried? Was he okay, or was he still worried about the situation? So do you want to just quickly vote about that? And I see somebody's already said that he's still going to be worried. And I don't think you can really take the worry away, can you? You can't solve everybody's problems. He is still going to be worried about his mum.
Absolutely.
Despite what you say, he's still going to be worried. And in fact, you can't take that away.
Can't take that away. You can help. Come up with solutions as to how they might deal with the situation, such as come with his mum to an appointment. Because of course that raises the issue of implied consent. So if Mrs. Thomas brings her son to the appointment, she brings him into the room, and you do briefly ask her, you're okay with us carrying on and talking about your health while Jack is here, that's implied consent because she's brought him to the appointment.
So let's look at how Jack feels, because we've got a little bit of a snippet of how Jack's actually feeling on the next slide. Okay, so that's a little bit about how Jack's feeling. He sort of understands. He's not particularly, happy, and he'll probably come along with his mum to the next point. And actually, in the next broadcast, we're actually going to see a consultation with Jack and his mum coming along, aren't we, really? So
absolutely, but don't forget the doctor in all of this.
Yes.
So,
how does she feel?
Absolutely. So as GPs, we are, well, I know I like to please. I like my patients to be satisfied when they leave my room, even if it is bad news that I'm giving them, or I'm not facilitating a request that they thought was quite reasonable. I still like them to feel happy, and it's quite difficult to say to Jack, actually, I know you're worried, and actually, at the back of your mind, it might actually be beneficial for him to know, because he's going to support his mum. But that you are bound by the GMC good medical practice and your duties as a doctor, and so you have to remember that, as tempting as it might feel, and although it might feel more comfortable to actually disclose that information, you must respect those boundaries.
Yeah. So we've got a little bit of a snippet about how she actually does feel, which is quite nice, actually. So let's have a look and see what she says. Perfect. Okay, I think that's really valuable advice, isn't it, really? I just wanted to recommend a couple of other bits of guidance. We've got other confidentiality guidance that's on those supplementary sheets. There's a couple. There's one about DVLA and Fit to Drive. Have you ever been in that situation, Marie?
Yeah, I have. So DVLA is our regulatory body. I can't remember what it stands for. Licensing authority.
Driver Vehicle Licensing Authority. Yes.
So you're bound by them when you take up a driving license in this country, and there are situations and medical conditions where actually you might be asked to do more monitoring, such as if you're a diabetic and you're known to have hypos. But there are conditions where actually you're not meant to be driving. So one of those is uncontrolled seizures, and I remember when I was training, actually having a consultation with a patient one late afternoon, and then and informing him that actually he needs to tell the DVLA about what is going on, and he shouldn't be driving. He was actually carer for his wife, and actually driving was a really important part of their lives, allowing them to, him to take her to appointments and him to do things like the shopping. And the next morning, as I pulled up to fill my car with petrol, who do I see at the petrol station? It's the same patient. And then, you might ask, what do? You can't physically go up to that patient and take his keys away, because that's not your job. But actually, you've informed him of his need to inform his legal requirement to inform the DVLA. What I did is I actually called him when I got back into the surgery and just told him that actually I had met him in the petrol station, and just reminded him that actually he needed to inform DVLA, and actually told him that if he didn't, then I'd be obliged to. And most patients respond to that. Most patients will then go and speak to the authorities and do the right thing.
And it's tough, and I, as you know, do some social prescribing, and last week we had a gentleman come in who actually had just lost his licence. He actually himself decided not to drive, which I think was the right thing to do, and we were recommending other free volunteer driving services that he could use to get to the hospital particularly, but also just do his shopping, and it's tough taking away that lifeline for people, but it is part of our responsibilities.
It is, and I mean other sort of confidentiality ethical situations that appear. I know I spoke to you a couple of weeks ago about HIV.
You did, and writing HIV on death certificates.
Yes.
So and the complications related to that.
Absolutely. So we talked about whether if a patient dies from a HIV-related illness, you need to obviously declare that on their death certificate, but a patient's family might not know. And are you bound by their confidentiality, the patient's confidentiality after they're dead?
Yeah.
And the answer to that was
basically yes.
Yes, you are.
But that you do have to state some of these illnesses because they are notifiable illnesses, so it can be really complicated to work up the ethical dilemmas in that situation. The conflict you find yourself in as a doctor, and so it's important to remember all those things, isn't it, really? And we, as the GMC, get lots of ethical queries, such as Marines, sent in to us. So if you are struggling with those really difficult ones, just send it in. I'll send you out with the recording of this when we send out the next sort of recording. I'll write that scenario. I'll write down what actually the advice is, if that's helpful.
Yeah, and have a read of it, because actually, I've been practicing as a GP and as a doctor for a while, but it still surprised me.
I'll do that.
So things have changed and come along a fair way. So have a read of that scenario. It's really interesting.
Yeah. Okay, so that's some great stuff. Now, Nick, we've got any questions? We have a little pause. Anything that's coming up on the discussion board?
There's no questions at the moment.
Lovely, that's fine, brilliant. Okay.
So in our previous broadcasts, you met members of our multidisciplinary team. So as I have alluded to in several different broadcasts, as a GP, we work as a team in our practices. So you've met the receptionist, and you've met the GP. Yeah. So now I'm going to introduce to you another member of the team, or another members of the team, who are the pharmacists. Yeah. So there are different types of pharmacists that work in practices. You're going to meet Solomon, who's our dispensing pharmacist. So he has more of a traditional role of a pharmacist, where you would go and collect your medicines from him. Yeah. But there are lots of other things that he can do, which we're going to hear about in a minute. The other type of pharmacist that I like to talk about is a clinical pharmacist. So our clinical pharmacist in my practice is called Anne, and she is fantastic. She's changed the way that we work since she's been there. It's been about a year she's been with us. So things that she does is she actions letters from hospitals. So, a patient might be discharged, started on new medication or stopped a medication, a dose might change. And usually that would come through to the GP. You'd have to read the letter, decide what you need to, what needs changing, go to the right screen, change it, issue it. So she actually does all of that for us. She can do reviews as well. So she has face-to-face consultations.
So she runs her own clinics?
She absolutely does. So medication reviews, I might have started an antihypertensive on a patient and I want them to have a blood test in a month, but also have their blood pressure checked, and we might need to up or lower their dose of antihypertensive. So she can see those patients. She sees some of our diabetic patients, and we have a very close relationship. So she's usually in the room next to me, and we knock on each other's door. Right. So recently I've had trouble getting hold of certain types of hormone replacement therapy, just due to local stocks really. And actually, I can't remember which brand is equivalent to which brand, and it would take me a long time to look it all up. So actually I'll knock on her door, and she has a relationship with the local pharmacies, so she'll tell me, actually, no, prescribe this one, it's equivalent, and actually it's available around here. So she's an absolutely valuable member of the team. And I know, because she's been off on leave and it's been a nightmare. So I've got a list of queries for her. And most practices now are looking at using the team slightly differently. So they're not just GP based. So you will meet other members of the team, such as a clinical pharmacist. You might meet a physician's associate. You might meet a paramedic. So in our practice, there's a paramedic that does visits. You might meet advanced nurse practitioners who have their own clinics, as they do in my practice, and they see lots of minor illnesses, or as well as the traditional stuff that nurses see as well.
So it's really to allow you to do your GP practice job more effectively, isn't it? Really,
absolutely.
To complement your role, but also take those other parts that somebody else can do, so that you can focus on the tough stuff.
And you might not be the best person to deal with that patient's problem, and that's a really important message that I like to tell patients. So for example, we're about to employ a physiotherapist. I see so many musculoskeletal problems in my surgery on a day-to-day basis. So lots of back pains, and I have the same old spiel about anti-inflammatories and exercises. But actually, if you had seen our physio rather than me, he probably would have given you those extras, shown you exactly which exercises to do, and come up with probably a better plan than I can, because that's what they specialise in. So these aren't alternative to the GP. These are other members of the team that the patient is better off seeing.
They complement you really well.
Absolutely.
And take over your role. Yes.
Absolutely.
Okay, so we have a look on Seek. So Jack has been given that script, and let's see what happens in the pharmacy. So a couple of things here. Firstly, we'll talk about payment in a moment, but it would be really good to sort of talk about antibiotics, because we know from speaking to lots of European doctors, don't we, that antibiotics are so readily available in Europe. You can go to any pharmacist, can't you, and buy antibiotics, but it's different in the UK. It's only on prescription, isn't it?
So it's only on prescription because we're quite protective of over our antibiotic prescribing, so we don't want inappropriate antibiotic prescribing for the obvious reasons that it actually causes resistance, and actually you're subjecting the patient to side effects that they shouldn't have, and eventually we're going to have to use even stronger antibiotics, if you like, which have more side effects. Something that I would urge you to speak to your supervisors about in your practice, because there are certain scoring systems which we use to help us decide whether we should be prescribing antibiotics.
And sort of balance it up,
So for example, for a acute tonsillitis, so obviously you'll all know that it can be viral or bacterial. We have scores like the Centaur criteria, which look at absence of a cough, the temperature. We have the fever pain score as well. And actually, if you're a little bit stuck, I urge you to use these scoring systems to help you decide, and also explain to the patient actually why they might not need antibiotics.
That must be a big part of your job, actually. Yes.
It is, but I think patients are now being educated about the importance of only using antibiotics when we know that there's a bacterial infection. And so actually that message is, I really don't have a problem with giving patients that message, and I can't actually remember the last time a patient said, well, just give me the antibiotics. In this scene, though, you might have noticed that that Jack actually had a delayed script.
Yes.
So a delayed script might be a sensible thing to do for somebody who is going to, is quite sensible with their health, understands, the importance of only using antibiotics when you need them, but actually might have a lot of difficulty coming back to the practice. They might, be working full time, or have difficulty, be a carer for somebody. So you could, like Dr. Kowalski said, you can send an electronic prescription to the pharmacy using the electronic prescription service, where there's no paperwork involved, and actually put a note on there that to be issued from day 3 or day whatever after you've seen the patient, and give the patient really clear instructions. So if you don't get any better, if you're still having temperatures, if actually when you're eating it's becoming more sore, then by all means go to the pharmacy and have a chat with them, and there will be some antibiotics there for you if you need them.
That's in Jack's case, which is quite good. Now, Jack paid for his prescription, didn't he? So he
did.
Wasn't exempt. And we're going to talk about exemption in a minute. So we'll go to a poll, because we wondered if you knew how much a prescription in the UK costs for a single individual medicine or appliance dispensed. So, lots of ranges, the price there, £8.80, £6.50, £9 or £10.50. Just wondered if people actually knew how much, because it so recently changed, literally very, very recently it's changed. So, some patients are expecting to pay a certain amount, and actually when they get to the pharmacist, they actually have to pay a little bit more. Somebody said £9, and you're right, it's £9. So thank you very much for that. Good. Okay, lovely. So it's £9. But if we go to the next slide, we can look at, there are ways of managing. If you're a patient who's, on a lot of medications, some of your patients will be on 6 or 7 medications.
And they might be lifelong medications, so paying £9, and it's per item, remember, so it's not per script. So you might have 4 items on a prescription. You might have a bit of, you might be hypertensive, and have, and need 2 different types of antihypertensives.
That's £36, isn't it?
Absolutely.
It's a lot of money.
It's a lot of money. So actually, we recognise that that actually can be difficult to pay for these. If you're using prescriptions, if you're using more than one item long term, and so we have prescription prepayment certificates. And the pharmacist usually does tell the patient about this if they recognise actually they're coming very often, or they've got lots of items on their script. So you can purchase a 3-month or a 12-month prepayment certificate, and this usually works out. So for the 3 months, if you're having more than 4 items, then it works out to buy a 3-month one, and if you're using more than 14 items and having to pay for 14 prescription charges in 12 months, then it works out to buy the 12-month one. And on that card, you can actually cash in as many scripts as you need to.
Got it.
So if you need 25 items that year, your 12-month payment prescription charge will cover you. So that's quite helpful for patients that are using a lot of scripts.
And I also think it's quite interesting to note how much other things cost as well, which we don't generally think, do we?
We don't. So I didn't know much about this, to be totally honest. I've come across the abdominal support, and actually I know that it's not the normal prescription charge, but go and speak to your pharmacist, because they'll tell you about some of these. I mean, some of these will be issued by the hospital, and so you won't have a prescription, and you won't have, so some patients probably, for example, a human hair wig after chemotherapy. I'm pretty confident that the hospital will help you with that, so you might not need to pay that prescription.
Certainly there are charities and hospices that also help you with those sort of things. You're right. So a friend of mine exactly the same, and she's got some funding for that. So so that's really good. Okay, there's another form. So when you make an application for a prescription charge, we put a screenshot of the form that you actually use.
So this is actually something that you will see very often in your practice, and you'll be asked to sign and date it, and have your practice stamp on it. So I thought it would be quite useful just for you to have a look at what this is, because you will be thrust this when you join us in the GP by the administration staff usually, or the patient, and be asked to sign it. So on the left hand side you can see a list of all the medical conditions that are exempt from paying prescription charges.
It's quite a long list actually, and I wondered how they made the list, because the list is, some of the things you think, I'm surprised about that. Do you know what I mean?
So there are some sensible things on there, things such as epilepsy, diabetes, and different types of, things, that you might need if you've got cancer. But there are things like hypothyroidism. And obviously we recognise that patients will require lifelong medication for this, and actually these are essential to their well-being and their health. But patients do get upset about this list sometimes, and they wonder why certain conditions aren't on here. And I think you just have to remember that actually this has come from a higher body, really.
Who researched it and investigated it.
Absolutely. But it hasn't been changed for a very long time, so I won't be surprised if there is a reform of this form at some point.
The other thing I was going to say, just make sure that you do actually fill in the patient's details on the right-hand side. Right.
There have been cases where doctors have signed the form at the bottom right-hand, written their position, stamped it, and asked the patient to fill in the details themselves. And then obviously the patient is free to whatever they like, and you put your signature on it. So do take the time and fill in those details.
And on the next slide is some times when you don't have to pay for prescriptions. Things like if you're over 60, if you're over 60, under 16, if you're a student in full-time employment, if you're pregnant, you've had a baby in the last year, which I actually didn't know. So that's actually really helpful, isn't it? Or indeed if you're an inpatient, if you're a patient in hospital.
Yeah, you don't have to pay for your medicines when you're in hospital.
And does that include when you get your drugs to take home, your TTOs as we would call them?
So you don't pay for those. No. Even if you're seen in a clinic, if your hospital doctor has written you a hospital prescription, and that looks slightly different to prescriptions that you might see in GP, which are green, they're called FB10s. It might be on a white piece of paper with a hospital's logo at the top. You go to the hospital pharmacy and get that medication, and you don't pay for that. Although there are some trusts where they do charge a certain prescription. So just find out what is available in your local area. The other form that I haven't put a picture up of here, but we've mentioned on this slide, is a medical exemption certificate, or the maternity exemption certificate. So when we see pregnant women as part of our general practice for their antenatal care. There is a form which you have to fill out where you sign what their expected date is, and the patient then sends it off and gets a little white card which allows them free dental care on the NHS, and all their prescriptions for free for the period they're pregnant and 12 months after.
And those are really important forms, aren't they? Really,
absolutely, really absolutely. Forms. But you'll be asked to fill them out quite frequently.
Okay. We have also got a question I can see, Nick, actually on the side of the screen. Would you mind sort of reading that out for us?
Yep, the question from Adams is, what is the place of family conference in the management of conditions like Mrs. Thomas's, and is it permitted by the GMC?
So with the GMC, it's all about permission, isn't it? It's all about checking with who you're having that conversation with, and if the patient's happy with that, basically.
Yeah.
But you have lots of conversations with lots of other people?
Yes, we do. So family conferences, we're not called family conferences, they're usually actually still called the multi-disciplinary team, and we do include family as part of that. So in hospitals, they happen quite often. So, for example, it might be a patient on a geriatric ward, and we're trying to work out how to discharge them. back to their own home and whether they need carers or any adjustments to their home. We do often invite in family members to talk about their relative and what they think might be, in their best interest, if you like. The patient might have dementia. We might want to know what the family think were their wishes about certain situations as well. In general practice, we do sometimes have family conferences. So Mrs. Thomas's condition is slightly different because she's actually got capacity, and she can come in and talk about her problems. And if she wants, she can give permission to Jack to come in and speak to the GP, or they can have a sort of family conference during an appointment. It might be a double appointment, so it might be a bit longer, or there might be some other time set aside during the day to do that. But things like safeguarding. So in child safeguarding or adult safeguarding cases, again, it's a multi-disciplinary team, but usually the patient's parents, and other parties that are involved in the patient's care, might be a school teacher, they are invited to the what we know in our area as MASH meeting, which is just a multi-agency hub. It is. So it's basically all the right people being in the right place at the right time to ensure that the patient is safe and actually they're receiving care to their wishes, or the best care that they can. So yes, the answer to that is yes. And I'm sure if that's something you're interested in, you can get exposure to through lots of different avenues in general practice, such as attending a MASH meeting.
Yeah, that would be really valuable. And certainly when you come to the UK, you'll have to do your safeguarding course, adults and children. So that would be the time that you look at that multidisciplinary sort of networking and talking about, like you say, safety of the patients, really. Yeah. So I hope that's useful. That's
a good question.
Yeah, it's a very good question, very good question. So we just wanted to point out to you that there's lots more about the role of the pharmacist. The role of the pharmacist is much more than just dispensing medicines, as you've seen Solomon do. And actually, we will also send you links to where you can see more of Solomon's interviews, because we've got a lovely couple of interviews with Solomon.
We have. So Solomon talks a lot about what he would do in certain situations, and how, for example, if a patient runs out of medication on a Saturday afternoon, and it's an essential medication they need on the weekend, actually how they can come to him and he can sort it out for them. Or he talks about the 111 service and how they can actually direct a patient to him. He talks about,
It's about blister packs, doesn't he? He talks about making up packs for patients so they've got the whole week's medication within a pack, so that they are not having to work that out for themselves. And he makes that up, and he talks to the patients about their needs. He delivers medication to their home, which is amazing, isn't it?
They do. I think pharmacists do a fantastic job in England, and so I'd urge you to listen to that video, which we'll send out to you, just to learn a little bit more about what he does and all the different options. I mean, he's recently started running a minor ailments clinic, so he can actually prescribe. So if someone needs antibiotics and they've got a sore throat, he can actually see them and use a scoring system and actually prescribe antibiotics.
He's got a little consultation room, hasn't he, next to his pharmacist? I saw him having.
So this is a good time to bring in our 360 virtual reality videos, which we will send you the link to as well. You can actually have a look around his pharmacy, so you can look, see his new room, look at all the things that are available over the counter on his shelves. So we'll send you that link. Have a play with it. It's really fantastic. It's an opportunity to really look at the environment that you might find yourself in England.
I think we've had the questions, and somebody has asked if it's the same presentation as we did in June. I don't know if you remember, in June there was massive technology problems. We wanted to do it again because we felt you hadn't seen all the videos, so that's why this is very, very similar. But we wanted to make sure, and somebody's noted that it is better this time.
Thank you.
We're just really aware of that, and we want to make sure you get the best, best quality service, really. So I don't think there's any other questions, is there, Nick? I can't see.
No further questions.
We're going to go to just a couple of quick polls at the end, and then we're going to talk about what we're going to do in our next presentation. So, Lila, would you mind, we're just going to ask you to rate the broadcast today, just as we do normally. It's just so helpful for us to sort of think how we can make it better for anybody. And again, if you feel we're missing a topic that you want us to cover, we have got some other plans for you, which we're going to talk about in a minute. But if you do feel we're missing anything, then we'd be really grateful if you just do that. And the last one, thank you very much for rating us, very good, very much. And the last poll is the last one, which is about whether you think this is useful for you in practice, which is another useful one. So do you think this broadcast will help you integrate into the NHS, yes or no? We're hoping it will, but we want to know if it doesn't, because again, we feel we're not meeting your needs, and that's really important. Okay, thank you very much. So the next slide is a save the date slide. We will send you out the details. But the next presentation, we're going to have August off because it's August and
summer holidays.
Generally people have August off, which is fine. It's nice. And our next presentation is on Thursday the 5th of September. And it's about the GP and the multidisciplinary team. And we're really going to look more, not about the pharmacist, we've talked a little bit about the pharmacist. Mrs. Thomas is going to come back, unfortunately she hasn't been doing so well, and she's going to come back for a conversation about end-of-life care, unfortunately. So, and she comes up with Jack, and we're going to look at that consultation. We're going to unpick things like advanced decision making, do not resuscitate. Yes. It's going to be a complicated one, isn't it?
It's going to be a complicated one, but one that I would, really strongly urge you to dial into. Yeah. It's a really big topic. Palliative care is something that we feel very passionately about as GPs in England, and I know it's different over Europe, but we play quite a big part in a very good team, I like to think, of district nurses, Macmillan nurses, the hospice, family members, practice nurses, as well as volunteers. So, join us and let's talk about things like the do not resuscitate orders, and also how you have that end of life conversation and what you're expected to really, talk to the patient about.
Yeah, and the GMC's got some great end of life guidance, which again I'll send you the link to. So try and have a read of the guidance before we start. It's just really helpful if you can just have a go at doing that. But we hope that you have a lovely summer. Our next slide is just our contact details, and please, these complex ethical issues are so complicated. Sometimes to write your individual one, Maureen or myself is really helpful, and we're very happy to respond individually to you. But also to take your thoughts, concerns, or interest in the International GP Recruitment Programme. And if you are interested in it and you haven't already got on it, then give us a shout and we'll point you in the right direction, really. It's going well at the moment, isn't it?
It is. Yeah. It's going really well, and it's been really great to meet you all. All these broadcasts are on the 14 Fish website, which you all can access. If you type into a search engine 14 Fish and IGPR, you'll see the videos there. But very shortly they'll be on the NHS England website under events on the International GP Recruitment Programme part of the website. So, and there's a little synopsis of each of them. So a little, you can have a bit of an idea what each one is about if you want to pick and choose. So please have a look at the broadcasts. Tell us what you think. We like to hear what you think. And any questions that you have. But it's been a real pleasure talking to you all today, and hopefully we'll see you again in September. Enjoy your summer.
Thanks very much. Thank you.